Thank you so much, Dr. Avai, for inviting me over to your wonderful course. The topic given to me is how do I enhance the use of multifocal intraocular lenses in my practice. As I was listening to Viraj and Samdesh give their wonderful presentations, I thought some amount of overlap is inevitable, but let me see whether I can try to minimize that and emphasize on points that have not already been covered. These are my financial disclosures, and obviously many of these companies are involved in the manufacture of intraocular lens implants. I think we as surgeons of the third millennium have to understand that Harold Ridley said in the 1950s that the first complication of cataract surgery is aphakia. Richard Lindstrom, the then president of ASCI, said in the late 1990s that the first cause of IOL surgery is presbyopia, and we need to evolve ways and means of addressing this in a reliable, predictable manner. I have seen that whenever I prescribe spectacles, there is an element of disappointment on the part of the patients and people accompanying them. Whether it's a 10-year-old getting his first pair of myopic glasses, the 45-year-old getting his presbyopic glasses, or the simple cataract patient who had a PMMA lens implant, and you think you have done a wonderful job and give him a pair of glasses, he or she says, but I thought after my cataract surgery I don't need glasses. So to me, spectacles very often translates to disappointment, and we need to address that. And obviously, if you are prescribing glasses, you would not leave cylinder, or you would not leave a certain amount of presbyopia uncorrected. You would obviously address each and every one of these aspects to get a perfect emmetropia for distance, near and intermediate. I think that's what we are moving towards, and that's what multifocal intraocular lens technology is all about. Having said that, and though I've been talking about this for almost 15 years, less than 5% of my patients actually get this wonderful lens inside their eyes, simply because there are, not just because of the cost disadvantage, but also because of certain inherent optical disadvantages that are involved. With a monofocal intraocular lens, we get a very precise focus, while with the multifocal intraocular lenses, you get a spread of focus, and essentially with the diffractive multifocals is 2 points of focus, and the distance between these two foci essentially depend upon the add power in the lens. The larger the power, the more is the distance of separation. Refractive multifocals, which are largely being given up, multiple foci, and that essentially induces dysphotopsia. So what exactly happens is, if there is 2 points of focus, one for the near, one for the distance, and if a person is looking at a near object, and there are a certain amount of rays of light getting focused from distance also, these rays constitute the noise, while what is looking at near, which essentially is objective regard at that point of time, is the signal. Is this signal to noise ratio which essentially causes dysphotopsia, and this is something that with every multifocal intraocular lens you have. In optics you get nothing free. If you need vision for all distances, you compromise in contrast. And depending upon the company from which you get this light, you would see these kind of halos and starburst phenomena, night vision difficulties being demonstrated in different ways. But the bottom line is that if you are going in for multifocal intraocular lens technology, there is a certain amount of compromise that you and your patient have to live with, and that's the reason that you have to emphasize to your patients that dysphotopsia may be a point that he or she has to deal with post-operatively. Your patient is coming to you essentially telling you that he finds driving in the night a difficulty, and that's one of the primary reasons he's coming for cataract surgery, or he's one of those Californian cataract patients who has to drive 60 kilometers every night back from work. Then maybe this is not the right choice of lens for him, and have to appropriately counsel them. Chat time spent preoperatively amounts to much less chat time being spent post-operatively. Some of these aspects have already been dealt with, but whenever I come across a multifocal intraocular lens patient, I have been using these right from the days of Array in the mid-1990s, and now I understand it's just not the intraocular lens alone. Preoperatively, during surgery, post-operatively, addressing these 5 C's, as they say, the cylinder and the residual refractive error, the capsular opacities, the cornea and the ocular surface, cystoid macular edema and other macular problems, centration of intraocular lens, which is already discussed, are primary reasons. If you address them even post-operatively, many of the complications, many of the complaints of these patients do go away. When my optometrist in his lane records a vision of 6 and 6 and sends the patient over to me, and they still have a lot of complaints. I often thought that these were patients who are difficult to handle, but today I understand this is because of limitations of our understanding, limitation of technology that's available to us. If we counsel them, if we treat them properly, many of these complications do go away. I think this is a classical case of garbage in, garbage out. If you are talking about emmetropia for all distances, primarily you have to get your emmetropia for distance absolutely spot on. So using the appropriate intraocular lens power calculation formula, using immersion biometry and a laser interference biometry is of primary importance. We usually measure with both these machines, make sure that the measurements do line up, and then only proceed with the intraocular lens implantation. And in case keratometry values do not match up, we again compare it with the topographic values, though usually it's the manual keratometry values that we attach more importance to. And again, the concept of microvision, monovision is something that has helped me so often. Usually I give a gap of at least 2 weeks between the surgery between the two eyes. It's not just for the first eye to settle down, but also for me to evaluate the quality of vision, the complaints that the patient has with his first eye. Just recording the vision as Sense 6 with your usual near vision chart is just not enough. The patient might be having a significant amount of difficulty in reading the newspaper, in holding his mobile and seeing the numbers on the mobile. In case it is near vision, which is good, but intermediate vision which is compromised, when I operate on the second eye, I pull down the amount of power that I'm implanting. That is, if it's 21.3 that's required, I'll implant at 21 diopters. But if it's vice versa, if his complaints are the other way. So bilaterally implanted, I find that I'm able to address most of these refractive complaints. The patient might be having 6/9 N6 vision in one eye and 6/9 N6 vision in one eye, other eye maybe 6/6 and N8 vision. But once you explain to these patients, they seem to do pretty well and adapt to the kind of condition that has come in. And in case you have inappropriate refractive outcome, we routinely offer a laser vision touch-up, laser vision correction, free of cost these patients 3 months down the line. Even if it's not that every small residual error I go ahead and treat, but if the patient is complaining about, I do not hesitate to go ahead and perform this procedure. Because these are small refractive errors, usually both the cylinder and the sphere can be adequately addressed. But you could do a surface ablation I rather do a correction with the flap lifted up, because this gives the patient so much faster recovery and the patients adapt to it much better. And just in case the patient says that he or she is not able to read in dim light, I do not mind prescribing glasses. Do not tell the patients that your vision is going to give at least 6 to 8 weeks. Don't be in a hurry to prescribe glasses. If they ultimately require it, you go ahead and prescribe it. Because if you don't do it, someone else is going to do it for them. And initially also, you never promise them total spectacle independence. Essentially, what you promise them is relative dependence on spectacles, and that's what you end up achieving most often. There are certain other modalities of treatment that are also available, which you could use appropriately for correcting an inappropriate outcome, and these have to be judiciously applied to get a satisfactory outcome. And sometimes when the patient complains of night vision difficulties, a certain amount of glare, etc., but says, I'm perfectly happy with my near vision, with my intermediate vision, what I do is to just slip on a -2 diopter lens and ask them to read a book. I say that I can exchange your lens, but when I do this, this is what you're going to have, this is what your near vision is going to be. Most often, they decide to stick on to their lenses, and over a period of time, because of neuroadaptation, they seem to do well. So essentially, you have to explain to your patients the benefits that are accruing from the treatment that they receive, rather than emphasizing on the problems that they have. This has been adequately covered. Making sure that the ocular surface is appropriate is most important. Almost 50% of the patients who present to you for cataract surgery have dry eye. And because of the drops that you instill, the procedure that you have performed, even the simple fact that you are rubbing on the conjunctiva damages goblet cells, there is a significant amount of dry eye. And once you address this adequately with lubricants, with the cyclosporin, with weak steroids, then you find that much of the problem that these patients have do go away with. Corneal topography, this has been addressed. I think determining cylinder, making sure that you appropriately treat these patients. Now we have the multifocal toric intraocular lens option also available. If cost is not a consideration, that's a great way to correct astigmatism as well as give multifocality. If there is a grossly decentered cone, if there is a keratoconus formifrustive that is pre-existent, maybe these are not patients who are fit for receiving a multifocal implant. I don't think I can better Samarish's presentation on eye trace. I think he covered it beautifully. But we ourselves employ this routinely for evaluation of every patient. But having said that, we don't entirely go by this. He said a golden value of 0.4 millimeters. There are umpteen number of patients I have come across in my practice where the angle alpha, the angle kappa, as you see in this case, is well beyond 0.5 millimeters. Because these were patients, we got this machine just about a year and a half back, but we were implanting these lenses quite regularly without knowing these values. And most of them were quite happy. So there have been many instances, even when I know it's 0.5 millimeters or above, I've implanted these lenses. When I know there is again a golden figure of corneal asphericity RMS value as 0.2 microns that is mentioned. There have been instances where I've gone ahead and implanted a multifocal implant in these cases, and we have found that these patients do not complain post-operatively. But when I look back upon the data of patients who are complaining after the multifocal implants, there are instances when pre-operatively the patients did have some problems. So we have the devices and tools to estimate this, evaluate these patients pre-operatively, but I think we are still in our infancy as far as understanding them completely and applying them clinically is there. OCT again is something that has been talked about. I believe that this is a routine examination that every cataract patient must undergo because almost 7% of the patients have a significant retinal abnormality. A cataract surgeon, I consider myself a trained vitreoretinal surgeon, but when I do a quick indirect examination or 90D examination, I can easily miss this epiretinal membrane. And this added on to the contrast sensitivity loss that comes in with a multifocal implant. If the retina is also subnormal, obviously you end up with a suboptimal outcome. These are common disorders, day in and day out, that an old patient, a patient in the 50s and 60s has. Early diabetic maculopathy, epiretinal membrane, age-related macular degeneration, lamellar macular hole, which an anterior segment surgeon, for that matter, even a vitreoretinal surgeon will miss unless a OCT is done. Parafoveal telangiectasia, vascular occlusions were largely resolved. If any of these conditions are detected by OCT, there is a strict contraindication for putting on a premium intraocular lens. I'm not going to dwell upon these, but these are some of my patients who received a who received a multifocal implant subsequent to a laser refractive cataract surgery. Initially, when I adapted this technology of femtocataract surgery, I was a little averse to idea of putting in multifocal intraocular lenses. I thought if the problem is due to the lens, the patient is going to blame it on the procedure. But today, majority of patients undergoing femtocataract surgery receive a multifocal implant or a toric implant simply because of the excellence of the technique, the uniformity of the rexus, exactly where you want, the size you want, the uniformity of the overlap. Time again and again gives us optimal results. I think marrying these two technologies is a significant way forward. Please do not get put off by that significant corneal edema. Simply because these are corneal incision, a significant amount of hydration has to be done. But if you see the first day post-operative pictures, these look extremely good. I think counseling is something that is extremely important. You need a sophisticated area where you have a well-informed counselor with the proper tools. It tells them all about the merits and demerits of this particular technology. Usually by the time I see the patient has already decided upon the lens he or she wants to have. Essentially, I just tell them three things if they have chosen a multifocal implant. That is, it is not total independence from glasses. It's just going to reduce your dependence on glasses. There is a certain amount of dysphotopsia that you need to deal with. And the third point is getting the second eye done early enough would be a good idea. And that might make them adapt to the technology much better. Once they accept this, I go ahead and implant these lenses. Usually the counselor spends a significant amount of time telling them about the advantages and the limitations of this particular technology. Please look at the kind of patient who is sitting there. Don't please go just by the dress of the patient, the appearance of the patient. There have been multiple instances when a simple looking patient who requires good vision for all distances is quite willing to invest in this technology and benefit from this technology, and they are some of the most satisfied patients that you can get. At the same time, do not give them excessive information. Most often, the patient wants, it's ethically right for you to give them all the information that they need, but most often the patients want you to decide is what is appropriate for them. So don't start with PMMA lens, go on right up to accommodative lens, then the patient is going to listen to everything that you have to say, but go elsewhere for the surgery. So pick and choose what's right for that particular patient, counsel them appropriately, and make sure that you are able to achieve it at the end of the day. Most important thing is stay with your patients right through. When the patient complains, it's not against you. Do not immediately go on the defensive. The patient says, I see halos or I have a little bit of glare when I drive in the night. You don't immediately start arguing with them. This is something I forewarned you. Why are you complaining? Most often, they want to be reassured. They want to be told this is something normal. This is something that might be able to become all right over time. There is ways by which I can address it. If a patient comes and tells me that I have a little bit of night vision difficulty, I immediately tell them, that's great. That means your lenses are working perfectly. That's the way these lenses work. And then go on to explain to them, reinforce to them why exactly this problem is happening. Look at all those C's that we mentioned about. If there is something that you can address, please go ahead and handle it. I think neural adaptation is something that's we seem to not understand too much, but that's extremely important. Every time you change your contact lenses, every time you change your glasses, there is a certain amount of neural adaptation that occurs. I do not know how many of you are aware that every newborn child sees everything inverted. It's only in the first few hours that because of cortical adaptation, the vision becomes the right way up. So obviously, once you allow enough amount of time, neural adaptation will take care of most of the problems that these patients have. So another thing is, do not be defensive about the expense involved. Obviously, if you want high technology, there is an amount to be paid for, and if the patient is willing to pay for it, go ahead and offer this with the right kind of values that is understood both by you as well as the patient. Most importantly, multifocal intraocular lens implantation is a practice differentiator. If you want to be noticed, you have to be different. So I think in that way, having something, offering this technology is a great way forward to build your practice. Thank you so much for your kind attention.
Thank you, Dr. Ramamurthy.